Good morning. I think the CSR is a very common clinical disease we come across in our practice. Before that, so I must thank AIO's midterm conference to give us an opportunity to speak in front of you. Thanks to the local organizing committee too. It's a wonderful conference. As I told you, CSR is a very common affection in our day-to-day practice in our country. And it has got a lot of synonyms, CSCR, CSC. So, but commonly we speak the term central serous retinopathy. It's a common retinal cause of visual loss. It's an idiopathic disorder characterized by localized serous detachment of the sensory retina at the macula, second to leakage from choriocapillaries through one or more defective RPE or outer blood retinal barrier. The main step treatment are observation, photodynamic therapy, and laser procedures. How to approach a case of CSR in your clinical practice? So first, you do a clinical evaluation. Predisposing factors are very common in these patients. They are mostly affected young males. And type A hypersensitivity persons, then steroid have taken some course of time in life. They have taken some steroids. And a lot of stressful life. That's why it is very common in young males, particularly about there are 30s, we get this disease. Symptoms, yes, the patient comes to sudden something blurred vision with a relative scotoma in the central visual field. They always complain that something black is appearing in their visual field. And sometimes they get a unilateral metamorphosia, micropsia, macropsia. So there is a drop of visual acuity in the 2 to 3 lines. This is continuous for some time. And if you do examine, there's a relative hyperemetropia, you see them, and a positive photostat test in these patients. And if you do a fundoscopy, typical circular rig reflex is seen in the fundus. Very commonly we see in our fundoscopy. And in the center of this reflex, the elevated macula, we see a small PED, white spot which is the cause of serous detachment. And of course, foveal reflex absent, and there is sometimes subretinal deposits are also seen in this area. And sometimes in the recurrent stage of choroidal, you get a multifocal pigmented changes. It's a typical picture of the CSR fundoscopy. You can see whether direct or indirect fundoscopy. Clinical course, yes, it resolves on its own within 3 to 6 months without any treatment, only assurance. But however, the recurrence is very common. It's usually bilateral disease in one eye affected, cured, and goes to the other eye. So chronic course sometimes lasts for more than 4 to 6 months and affects about more than 50 years, affects more than 50 years old males, and may have permanent visual impairment due to the progressive RP atrophy. Bullous, sometimes it's a large bullous CSR can be seen in the macular area. It's very commonly when following systemic steroid therapy. Differential diagnosis, there are so many things, but very common as the CSR is very typical. You can differentiate from the optical disc pit, PCV, macular hole with the serous detachment, and coronal tumors. Investigation is the best common investigation we do in the OPD, the amsler degree test that detects here the early changes in the macula. Then OCT, the really diagnostic of this disease, we'll see a serous space in the macular, retinal layers. And sometimes you get one or more smaller RP detachments too. Sometimes you get the precipitates on the posterior surface, the detached retina and thickened choroids. Very, typical picture of CSR. FFA, yes, again, they are very typical. If you do FFA, you'll see the typical ink blot pattern, small hyperfluorescent spot which gradually widens, and smokestack appear pattern, small hyperfluorescent spot which extends vertically like a smoke stack and gradually spread lateral to an umbrella pattern or mushroom pattern. And diffuse pattern, yes, sometimes it doesn't configuration to any of this, we can get a diffuse pattern too. Aims of treatment, the aims of treatment for CSR to preserve the outer sensory retinal layers, neurosensory retinal layers, to achieve complete resolution of the serous retinal detachment and unlike subretinal fluid. It means small amount of subretinal fluid present in the subretinal space can lead to irreversible damage to the photoreceptors in the later stage. Treatment, as I told you, observation assurance in the most cases they resolve on their own. But as the patients, because the patient is usually young males, they are in their job, they find a lot of difficulty in doing the computers, everything. So they complain they are not able to do that. Sometimes they need some treatment at that time. But those are the treatment is just like some vitamins, etc., some assurance with the cures. So the vision returns normal within 1 to 6 months. The majority of cases of acute CSR, they disappear with observation only, and some lifestyle modifications necessary. If they are taking steroids, you have to stop the steroids. So management of chronic disease is very more challenging than and may include either the medication or laser-based treatments. So sometimes give the medical treatment like mineral corticoid receptor antagonist, epirolone, spironolactone, 25 milligram per day for a week, followed by the 50 milligram per day for 3 months. Rifampicin long time back, sometimes the tuberculosis is imposed on this CSR as the cause, and we have seen after giving rifampicin course of 5 to 6 months, it resolves very nicely. So now we can also recommend 300 milligram twice daily for 3 months. Estazolamide, yes, sometimes it reduces the bacterial fluid collection, so 250 milligram per day in divided doses can be given to reduce the side effects. Melatonin, propranolol low-dose aspirin can be tried in these cases to give some relief to the disease. But again, anti-VEGF treatment is again controversial. Yes, whether you would like to give anti-VEGF in these cases or not, but sometimes we give anti-VEGF as a part of some other treatment to see that there is a complete resolution of the disease. So reduce the vascular leakage of the tight junctions of the endothelium, reducing the leakage from the choriocapillaries to the subretinal space. Thus it cures the disease, so anti-VEGF can be tried. Lasers, yes, if the patient comes with a recurrent CSR or long course of